Hello and welcome back to the Neurotransmitters. I'm your host, Dr. Michael Kentris, and I'm joined today for a very special treat with Dr. Andreas Charidimou, a neurologist and researcher at Boston University Medical Center and Boston Veterans Center. Andreas, thank you so much for joining me today. I am really excited to pick your brain about a number of topics.
Thank you so much, Michael, for the invitation. I'm also very excited talking with you this morning about small vessel disease, CA, and whatever else.
Yes. Now, for those who aren't familiar, we've known each other for a while on X, formerly known as Twitter, and had the chance to meet in real life, as the older millennials say, at the Academy meeting this last year. But this is our first time to have a kind of a longer conversation about what I consider like you're the guy for like cerebral amyloid angiopathy, and do a lot of teaching online about different types of ischemic disease to the brain. So if you could just kind of, for those who might be less familiar, when we're talking about small vessel ischemic disease and how that relates to kind of the development of brain pathology, if you had to give just the 50,000 foot view, how would you characterize it?
Yeah. That's a good question, actually. So I think we're all familiar with the large vessel disease, ischemic strokes, for example, cortical infarcts, these kind of things. However, there are small vessels in the brain, and they're affected by different pathologies. And the definition of how small a small vessel needs to be in order to be considered a small vessel, it kind of is a moving target. But in general, we're talking about arterioles and smaller, so 500 microns and smaller. And these small vessels, they're affected by some pathologies were particularly prevalent. The first one is kind of vascular risk factors driven, diabetes, hypertension. The same way they can cause atherosclerosis. In smaller vessels, they call arteriolosclerosis or lipohydinosis. So it's kind of a vascular risk factor driven pathology. And the other pathology is what is called cerebral amyloid angiopathy, which is entirely different in a way because its characteristics is amyloid beta deposition in these small vessels, especially in the cortex and the leptomeninges. So when we say small vessel disease, we kind of mean at the basic level these two pathologies. However, with all the advances on imaging, the term small vessel disease now applies to also imaging manifestations, microbleeds, white matter hyperintensities, or it might apply to clinical syndromes, for example, lacunar infarcts. The disease can be approached at three different intersecting levels, which kind of reflect how the knowledge and technology progressed from pathology to imaging and then integration.
Excellent. Thank you. And as we were talking about just before we started recording, my knowledge, thanks to you and other kind of vascular neurologists in the last few years, has really put cerebral amyloid kind of on the map for me. But before we get to that, I know a lot of times in a lot of parts of the country, we have, primary care physicians who maybe don't have neurologists immediately available. Maybe they've gotten an MRI of the brain, and, it shows some bright spots or these T2 hyperintensities on the images. And, you get this report back from the radiologist, and it's like, could be seen with migraine, stroke, demyelinating disease. So for those who aren't as familiar, how would you go about kind of differentiating these? Let's say that they're a particularly ambitious person, and they open up the actual films themselves, and they're looking at like kind of the T2 flare. What are the characteristics that help us differentiate sort of small vessel disease from, say, like the typical migraine hyperintensities or kind of the UBOs or unidentified bright objects that we sometimes talk about?
Yeah, that's a very pertinent question, and this scenario often leads to many downstream extra tests, which might be harmful for the patient.
Absolutely.
I would say the first piece of information, even before opening the actual MRI, is the clinical context. It's different if you see these spots on a 20-year-old female patient versus a 75-year-old patient with hypertension. So the clinical context is very helpful in terms of the pre-test probability. For example, white matter spots in a 75-year-old, the probability of that being a demyelinating disease is very low, just based on that. So there are a few things that you can use in addition to the clinical context. I think the first one is the pattern. Typically, small vessel disease associated bright spots on FLAIR, they're often periventricular. They're just around the ventricles, which basically the reason is that those are very vulnerable regions in terms of perfusion. Or in addition to that, they might have some small subcortical spots, which are kind of widespread in the brain. But you don't really see the spots, the subcortical spots in isolation. That's one thing. The second thing is basically if you see white matter spots in areas you wouldn't typically expect, for example, corpus callosum. Typically in small vessel disease, you don't get, at least in initial stages, white matter lesions there. If you see a predominant pattern affecting the temporal lobe, for example, or around the basal ganglia, should make you think of CADASIL. So there are all sort of information regarding the pattern of this and how they look on the MRI. The other thing I would add is how extensive they are. For example, many inflammatory or autoimmune conditions of the brain, they can cause edema and white matter spots. There are other ways to differentiate them, but to the eyes of a general practitioner, they would look the same. So the extent, the symmetry, and when it comes to small vessel disease, sporadic small vessel disease, the extent is often hard to judge because we don't have any normative data. When is white matter hyperintensity too much for any given age? We don't have any normative data from healthy controls to compare. So yeah, the combination of clinical context makes you think demyelinating diseases or just associations with migraine that we typically see in these patients if they get brain MRIs, their pattern, their extent, and then you can also use other brain MRI sequences to characterize what travels along those white matter damage. For example, is it an area of gliosis actually because the patient had an infarct? Is it a tumor with edema? So all of these, they come into play. That's why usually the radiologists, they give a huge list of differential.
Right.
This imaging manifestation does have a huge list of differential, but taking into account the clinical context, the pattern, and other sequences, you can nail down to maybe 2 or 3 differentials, which is already a great start.
Excellent. No, that's super helpful. So kind of going from this small vessel ischemic disease, and we touched on it just briefly earlier, related to cerebral amyloid, which is, again, I consider you to be the person who's probably taught me the most about CAA in my short career. But we talked about the deposition, and a lot of times, tell me if this is wrong, how I characterize it when I'm talking to patients is it's almost like Alzheimer's of the blood vessels in the brain. Is that too simplistic? Am I being too simple? How would you say?
No, actually, because I use the same kind of analogy when I explain this to patients. That is the Alzheimer's equivalent of the vessel. The only problem when using this equivalent is that the term Alzheimer's has a huge emotional load.
True. That is a good point.
Yeah, but both conditions are they're like cousins in a way because they're both characterized by amyloid deposition of different forms, one in the vessel, one in the parenchyma. But it's a good analogy to start.
And so how would you, like, if you have someone? So first of all, when should we start thinking about CAA as a potential diagnosis? Like, what are the kind of clinical events that kind of bring it to the forefront of mind?
Yeah. So first of all, CAA is a very common pathology as we're growing older. If we're lucky enough to live in our 80s or 90s, I mean, most of us will have some degree of CAA. And in most in most people, probably doesn't cause any problem because it's very mild. Now, when patients come to the hospital, the clinical syndrome associated with CA, I think of them as stroke syndromes and kind of memory clinic or cognitive syndromes. Among the stroke syndromes, the first one that was really characterized and is very well known is presentations with lobar intracerebral hemorrhages, which in many elderly patients is due to CAA plus or minus other exacerbating risk factors, blood pressure elevations, and this sort of stuff. The second stroke syndrome is with acute convexal subarachnoid hemorrhage. So you have an isolated subarachnoid hemorrhage in one of the cerebral convexities, in one or two of the sulci in the brain. And often these patients present with what is used to be called amyloid spells or transient focal neurological episodes that we can discuss later if you want, what are their characteristics and how you should think about them.
Yeah.
So in my mind, acute convexal subarachnoid hemorrhage and amyloid spells are kind of linked. The one is the imaging, the acute imaging manifestation. The other is a clinical syndrome. Then in terms of memory clinic presentations, CA can either present as like a pure vascular cognitive impairment kind of syndrome in patients that are very severely affected, but most often it presents as a co-pathology in patients with presumed Alzheimer's disease, Lewy body dementia. So you see stigmata of the disease on the brain MRI. And in those patients that is a co-pathology, it's hard to characterize the contribution to specific cognitive domains. In those that it's the primarily driving pathology, the cognitive syndrome is exactly that of the vascular type of cognitive impairment. Frontal executive, visuospatial would be like early affected. And then we have presentations, again, acute, which do not fit with either. They fit with acute neurology, and this is the CA-related inflammation, which is basically, it has a huge range, but at its core is a syndrome of encephalitis type of presentation with a lot of confusion, seizures, cognitive impairment, and it can be either very acute or it can be subtle and subacute. Within this context, I consider ARIA, amyloid-related imaging abnormalities, as one emerging clinical scenario where CA might be relevant. Basically, ARIA is iatrogenic CA-related inflammation. It's in an oversimplification, this is what it is.
Right, and I know with the kind of the advent of all of these anti-amyloid therapies that are coming to market, for better or worse, I know there's still a lot of hotly contested questions about how they're implemented and so forth. What role do you think this like perhaps undiagnosed or kind of lurking in the background, this CAA aspect of Alzheimer's potentially, or this co-pathology with Alzheimer's, is the driving force for why some patients develop ARIA and others do not?
Yeah, I think that's the million-dollar question. It's the core of the issue. And as I was discussing before, in the behavioral neurology world, CA was kind of neglected, or it didn't have like a primary role, but now it does have, because it affects treatment decisions. We have limited pathological data. That's the problem with anti-amyloid treatment. But even with those limited data from 3 or 4 patients that actually died from ARIA, it seems like the primary pathology was destruction of the vessels, which vessels were heavily affected by amyloid deposition. So it's some sort of inflammatory reaction triggered by the anti-amyloid antibody within the vessel wall, which has amyloid. So this makes me think that probably underlying CAA in the brains of this patient, it is a real risk factor for developing ARIA. And this is kind of what all the trials and now the guidance that we have from FDA is trying to select by saying that you shouldn't give any of these treatments in patients having 4 micromillis or more. the underlying idea is that you're trying to exclude patients that, I mean, why do they have microbleeds? And I'm talking about lower microbleeds. Most likely
Right.
is because of CA. I don't believe hypertensive arteriopathy with deep microbleeds poses any significant risk for ARIA. So you're kind of trying to exclude patients who have very obvious and probably significant CA manifested as microbleeds. But this is not enough because that's only the tip of the iceberg.
Right. And yeah, that's one of the, I think back to, the Boston 2.0 criteria, of which you're one of the authors. And, I know it's kind of broken down into like the definitive, probable, possible, so forth. But I mean, the definitive camp, right, requires biopsy, right? You have to have tissue,
Yeah.
which I imagine most people aren't lining up to have done.
Yeah, I agree.
So, in terms of like the probable camp, how sensitive are these criteria in someone who maybe hasn't had a clinical event?
Yeah.
They're coming into let's say the cognitive
Yeah.
clinic, and maybe they have like one or two lobar microhemorrhages. They don't really meet the full criteria, perhaps. How does our current understanding of like making a diagnosis in someone who maybe just has a cognitive subtype, and then kind of risk stratifying them, or is that something that's kind of still in flux?
Oh, it's very much in flux, but this gives a good opportunity to discuss about the structure of the criteria, of the Boston criteria. And for important historical context, these criteria were drafted in the mid-90s as an effort to diagnose CA-related hemorrhage. They were never designed initially to capture CA pathology. They wanted to assign the probability of a lobar hemorrhage being due to CAA. So that's one thing. So they're very heavily drifted towards hemorrhagic presentations, with microbleeds and hemorrhages being the core of defining the categories in previous versions. Now, the structure, as you alluded to, the definite, requiring pathology, probable, and possible, it kind of reflects how all the criteria in the field of cognitive neurology was defined in the same time. Like you have definite, probable, and possible for Lewy body dementia, for temporal dementia. So it was like a familiar way for clinicians maybe to think about the criteria. I personally think that this is outdated, at least for CA, because definite, you almost never have pathology. You wouldn't get a biopsy in any of these patients.
Mm-hmm.
Possible categories is a very shaky category. The way I explain that is that it's a possible category for CAA and a possible category for non-CAA. I see it as like 50-50.
Right.
So the probable category is the one that we typically use. And what we have done in the criteria is that we have expanded that category to include not only presentations with at least two hemorrhagic imaging markers, two microbleeds or siderosis microbleeds, but to be allowed to make the diagnosis when you have one of these hemorrhagic biomarkers plus one of the non-hemorrhagic biomarkers, white matter hyperintensity spots or perivascular spaces in the cerebral white matter. In this way, we try to expand the catch, especially for non-hemorrhagic presentations. Now, how good are they in the setting of memory clinic? The answer is that we don't know. We don't know how sensitive or how specific they are. We have some indirect data and some data that are under publication, looking at different cohorts within the memory clinic or the general population. And the overarching conclusion is that the Boston criteria are not very good in diagnosing probable CA in the context of the memory clinic. They have low specificity and a bit higher, low sensitivity and a bit higher specificity. So we're missing a lot of these patients. Of note, I don't remember which conference it was, but there was an abstract that they compare in a memory clinic how many patients can be diagnosed with possible or probable CAA based on the old criteria and based on the new ones. And if I remember correctly, based on the old criteria, they could make the diagnosis in around 15 or 20% of the patients.
Hmm.
Whereas with the new criteria, they can diagnose possible or probable CA in up to 45% of the patients.
Oh, that's quite high.
Yeah, but it's more in line with what we know from pathological studies, that in a memory clinic setting, up to 40% of patients might have mild or moderate CA. So to wrap it up, is that just by saying it's an active field of research,
Hmm.
and we don't really know how good the Boston criteria are in this setting. Probably they're not as good as in a patient presenting with lobar hemorrhages or convexal subarachnoid hemorrhage. And I believe we need other markers and probably a somewhat different set of criteria. When we're publishing the paper, the focus and the material we had was primarily from hemorrhagic presentations rather than memory clinics.
Hmm. I know, to what you said earlier, right? These are obviously the small vessels that aren't imaged well on most of our conventional studies. Are there any either like biomarkers or imaging markers that are currently like being investigated that you think have promise?
Yeah, in terms of non-MRI markers, the two avenues of research that I have to say they have been stagnant for a long time is amyloid PET and CSF biomarkers. Amyloid PET is a bit tricky because the amyloid radio tracers, they label both parenchymal and vascular amyloid. So a positive amyloid PET scan in the setting of a memory clinic, who knows? It's going to be
Right, that's tricky.
parenchymal plaques, plus or minus CAA. So you cannot really use it. There was the idea that maybe a posterior predominance of amyloid PET binding might be more specific for CAA, given that we know from pathology that CAA affects more posterior cortical
Hmm.
regions, but the effect size of that association is very small, and I'm not sure you can reliably detect that by naked eye on an amyloid PET.
Hmm. I wonder, and maybe you know more about this. My thinking back to my own training in epilepsy. Did they ever do like amyloid PET co-registration to MRI to see like if it superimposes on areas with like really confluent white matter disease or anything like that? Does that have any correlation? I imagine someone has to have had to look into that in the past.
Yeah, they have looked at that in relation to lobar microblitz. And it was found that there is a shell of amyloid PET binding around microblitz of higher uptake. For white matter damage, I don't think so. I don't think it was tested.
Okay.
But it's a good idea, the co-registration. Uh,
Yeah, I don't know. Yeah, it's really challenging. And as far as like the CSF biomarkers, does that kind of fall into that neurofilament light chain family of investigation,
yeah, so
or it's something unique?
exactly. So we need something unique, and CSF biomarkers, they offer the possibility of something unique. So of course you can measure T tau and P tau and all of those neurodegenerative biomarkers.
Hmm.
But what might tease apart CA from other pathologies is the amyloid beta species. So you can measure the CSF and characterize how high or low are the amyloid beta species. And in CA, amyloid beta 40 is the species that presumably gets deposited in the vessel wall
Ah.
more than amyloid beta 42, which is the predominant amyloid beta species in amyloid plaques. So on CSF, low levels of amyloid beta 40 and other amyloid beta species with less than 40 amino acids, so amyloid beta 38, they seem to have a great promise and a great discriminatory value in teasing apart CA versus Alzheimer's disease.
Interesting.
Yeah, and
Yeah.
serum biomarkers
Yeah.
the Alzheimer's disease field is kind of moving into the serum biomarkers.
Right. Yeah, because it kind of goes back into that thing where if we look at like the incidence of Alzheimer's and by association the suspected coincidence of things like CAA, how many of these people, one, just in terms of like societal costs, getting lumbar punctures, the invasiveness of the tests, a lot of these people are probably on antithrombotic therapies, maybe even anticoagulation. What's the risk of holding these for an invasive procedure? And it becomes this kind of mounting logistical barrier to getting to a definitive diagnosis in people, a vast majority of people.
Yeah. I don't think you need to get a definite diagnosis in the overwhelming majority of people because the idea of diagnosis is only changing when it's going to change management, right? Sometimes
Good point.
you don't need to know all the definite co-pathologies in any given patient if it's not going to change the management or if it doesn't have any huge clinical relevance. CA is becoming very relevant because an accurate diagnosis in the memory clinic in Alzheimer's disease, it might actually be the decision point for patients getting anti-amyloid disease-modifying treatments or not. And those are not the overwhelming majority of patients. There was a study from the Mayo Clinic memory service, and they analyzed all their patients, and they found out that about 5 to 10% would be eligible using current eligibility criteria to get anti-amyloid treatments. So in that fraction of patients, if we want to make anti-amyloid treatment safer, we need to improve our accuracy in diagnosing CAA. So maybe in those patients, a lumbar puncture might make sense, and the risks and benefits.
And you probably know the numbers better than I do, but if I remember right, it's around 20-ish% of people who are qualified candidates for this have the risk for ARIA. Is that correct?
So asymptomatic ARIA, just based on imaging, is about right, between 15 and 20%. And then symptomatic ARIA is much lower in the range of maybe 3 to 5%. Mm-hmm. But the asymptomatic ARIA, the one, the little asterisk, is that we don't really know what are the long-term consequences, because having more microbleeds in the brain or more areas of white matter damage, it's not a good thing intuitively.
Right. And I know I've seen some cognitive neurologists out there talking about like at the end of these trials, like total brain volume is diminished and, all these other things you had mentioned. And it's like, we really don't have the longitudinal data to say what does that mean from a clinical perspective. And that's always a little nerve-wracking when we're talking about like the risks and the cost and all those sorts of things.
No, it is. Plus, we don't have long-term data to see if the curves of benefit in those getting the treatment versus placebo, they continue to diverge, or maybe after 3-4 years they have the exact same path, irrelevant of whether they got the drug or not. That's also a bit is not satisfying.
Right. I know there's lots of debate, lots of hot takes out there online. And I'm certainly not an expert in that particular field, but it's always good to see that there is a robust discussion from both sides.
Yeah, I think there is a robust discussion between people that they focus a lot on the benefit and people who focus a lot on the risk. Mm-hmm. In any case, at least lecanemab got FDA license, so you cannot take the clock back. But the debate is still relevant to make the treatment safer.
Yeah. And, just more of an opinion from you. If I remember right, I think the UK did not approve. I don't know if it was aducanumab or one of the other anti-amyloid therapies, but I know in Europe, there's been a lot more hesitancy towards the approval from the regulatory boards as far as these go.
Yeah.
Does that speak to anything, just maybe a difference in philosophy or maybe a more stringent criteria in terms of showing benefit?
I don't have inside information, so I don't know for sure.
Absolutely. I'm not going to hold you to it.
But I think it's a combination of those two things. Maybe they're a bit more strict compared to the FDA in how they review all of these new treatments. Plus, maybe there is indeed a difference in philosophy. In general, I notice in the US, there is a tendency of having a pill or a drug for everything to fix everything. But when it comes to dementia, it's even in patients getting anti-amyloid treatments, there's a lot more that goes into the dementia care, and how, at the end of the day, the question is not how to remove the amyloid effectively, but the question for this patient is that how can they live a fruitful and a nice life despite having Alzheimer's? And maybe part of the story is removing the amyloid, but there are a lot more elements into it. So I'm not sure. And I think European boards are even more hesitant based on what happened with aducanumab, which was it was a big failure, I believe, in how the story evolved.
Yeah, it definitely wasn't the thing that a lot of people were hoping for, I don't believe.
Yeah. Having said that, I truly believe that despite the failures in general in the Alzheimer's disease field, it's positive that we're moving towards more treatments, which means that the private sector and all the companies, they have a renewed interest in investigating a bit more in this disease and trying to find beneficial medications. Because when aducanumab turned out to be very risky compared to the benefit, many people, especially companies, they started closing their neuroscience programs looking at dementia treatments.
Right.
So in general, I think it's a positive step. The question is how we can make it safer and beneficial at the end of the day.
Right. No, I think that's absolutely true. So I know we've kind of beaten the dementia horse for a while, but I work a lot in the hospital, and something that always comes up, we have these transient neurologic events or transient focal neurologic events, and I know the temptation for many of us, and maybe even more so for non-neurologists, is to call any transient neurologic event a TIA or a seizure, but it's probably accurate that there's something in between the two, perhaps. And as we kind of hinted at earlier, they used to be called amyloid spells. A lot of my instructors are a little old-fashioned, and so we would call anything that we weren't definitive was a seizure, it would be a spell, which I know is not currently in vogue, but I have a certain historical fondness for it. But could you tell me a little bit about amyloid spells? When should we consider them? How do we go about proving them to the best of our ability?
Yeah. This is when I came across patients with these symptoms. My PhD supervisor at the time, David Waring at UCL, he used this term amyloid spells. I'm like, oh, this sounds fascinating. It's a spell. Is it caused by amyloid? Why is it different to a TIA? So, yeah, it's a very interesting question. The first step is to know, as you said, that not all transient episodes, transient symptoms in neurology are TIAs or focal seizures. They could be a number of things. They could be like a migraine aura. They could be functional symptoms, or they could be amyloid spells or CA-related transient focal neurological episodes. So it's hard to make the diagnosis just clinically, the same way it's hard to make the diagnosis of a TIA just clinically before you do brain imaging, I mean. But some of the indicators that maybe you're dealing with something that is not a TIA is, first of all, positive symptoms. Typically, TIAs, they cause negative symptoms, so loss of function, upper extremity weakness, or aphasia. The prototypical amyloid spell is a spell that involves migrating paresthesias from the arm up to the mouth, which resolves in a typical microdary fashion as well. So this is one indicator. Although we now know that some amyloid spells, they have negative symptoms. So if you have this migratory positive nature, it should make you suspicious. But if you don't have it, it doesn't mean it's not an amyloid spell. Now, the other thing which is very atypical for a TIA is to have recurrent stereotypical episodes of the exact same symptoms, exact same pattern. You don't get that with a TIA just because different areas are affected depending on what's the mechanism of the TIA. You might have that with a focal seizure, though. So again, none of these clinical indicators are very specific. The other indicator is when you have, let's say, transient neurological episodes in a patient without any vascular risk factors, or in a patient that you have excluded any, carotid stenosis and any other sort of sources of emboli. Let's put it this way. But it's not enough. All of these are just indicators. When present, it should make you think more about amyloid spells. When they're absent, they don't mean patients do not have them. So the key after having amyloid spells in your differential is to get blood-sensitive sequences on the brain MRI, because that's the only way you can diagnose CA, and that's the only way you might find the underlying cause of these amyloid spells, which in the overwhelming majority is acute subarachnoid hemorrhage in an eloquent area of the cortex, depending on where the symptoms are. Or depending if the patient came immediately to the hospital or after a few days, you might only see cortical superficial sclerosis, which is like the chronic form of subarachnoid hemorrhage.
I think there's...
And of course, yeah.
Oh, sorry, go ahead. Go ahead.
I was about to say, with the brain MRI, of course, you have ruled out other causes of these symptoms.
So that was the other thing I wanted to ask you about, because, I know sometimes you'll get the MRI back and there'll be this tiny little punctate area of restricted diffusion as well, like very, very superficial on the cortex, like literally just like 1 or 2 millimeters across. And maybe it correlates with the symptoms, maybe not. In what context, or I should say, how far are we looking for, some sort of like embolic source of stroke versus attributed more to an amyloid etiology?
Yeah. So are you referring to the scenario that you suspect a patient might be having amyloid spells? You do the brain MRI, but you see no siderosis and no subarachnoid hemorrhage.
Correct.
In the area you expect, but instead you see a small punctate DWI lesion.
Right.
So in this scenario that you haven't found any sort of chronic or acute bleeding in an area that can explain the symptoms, and you have a DWI lesion, in this scenario, you need to look a bit hard for embolic sources, including in addition to cardiac echo, long-term monitoring, and you go all the way towards that path of embolic stroke workup. However, if you have a patient that, in addition to those tiny DWI lesions, just above the cortex, they have acute subarachnoid hemorrhage or cortical superficial siderosis, I don't think you should look very far for embolic sources, because we know that in these patients with CA and acute superficial bleeding, we often see small DWI lesions in that area just below where the bleeding has happened. And I'm not sure what's the exact mechanism. Maybe it's cortical spreading depression in patients that basically all their vessels, they lack autoregulation. So it's easier to get small DWI lesions, or I don't know if there's any other mechanism.
Because I recall a few years ago, I had this huge run when I was covering the epilepsy service of we're doing all these long-term EEGs on these patients in the neuro ICU who were coming in with subdural hemorrhages. And, obviously, depending on the size of the bleed, that diminishes your sensitivity on your recording. But you would watch them for 24, 48 hours. You'd capture the spells. There wouldn't be any electrographic changes. And it does make me wonder, like, are we seeing, the best I could find were some theoretical papers at the time talking about that exact same thing, right? This spreading field of depression, which I feel is like this phrase that we as neurologists throw out for anything that we can't explain otherwise.
Like inflammation.
Right, and inflammation. But yeah, it does seem like all these same mechanisms do apply, right? It's not necessarily vascular, it's not, electrical, it's kind of the combination of the two. And we see this with all of these disorders that are kind of transient migratory, migraine, seizures, other kinds of like vascular events that aren't clearly TIAs or strokes. And it does make me wonder, like these are all kind of happening on this spectrum, is there any role for amyloid spells, like, assuming that we've ruled out TIAs and strokes to the best of our ability, for any like anti-seizure medication or anything of that nature?
Yeah, that's also a very good question that comes up very often. So the answer is that there is a role. Again, as in most areas of CA, we're in uncharted territory in terms of randomized controlled trials. There are 0 randomized trials of what we're talking about. But the anecdotal clinical experience with these patients is that the episodes, they tend to diminish on their own. The reason being is that the acute blood gets absorbed and gets degraded down the line, so it's not so irritating to the cortex. However, we have had patients that they have 10 or 20 of these episodes in a single day.
Oh.
So it's quite bothersome. If the patient thinks the episodes are bothersome, then prescribing a short course of anti-epileptic medication is not a bad idea. At least you're trying. But I wouldn't keep them more than like a month or two, because I would assume the episodes should subsided by then.
Interesting.
So there is a role, but not in all patients. And again, I'm not even sure if the anti-epileptics are working in this scenario or just time.
Right. Yeah, that's a good point.
Yeah, makes the episodes go away.
I know that's one of the things that we'll sometimes do, is like basically like an empiric, therapeutic / diagnostic trial of meds. Like, I'm not sure what these spells are.
Yeah.
Try this for come back in a month. Tell me if they go away. And especially in areas where you can't get folks into like an epilepsy unit or something like that for closer monitoring, you do kind of have to just try stuff sometimes, which can be challenging.
No, it is because most of these patients are elderly, so you wouldn't want to have them on an anti-epileptic without any reason. But
right,
in some of them, it's not unreasonable to try.
Right. Yeah, especially there's some that are relatively low risk as long as they don't interact, and et cetera, et cetera.
But it's important for whoever makes a diagnosis or to continue following these patients, because as you probably know better than I do, as soon as there is a patient on an anti-epileptic, if they go to their PCP or anywhere else, how likely is it to ever stop that anti-epileptic?
Oh, never, ever.
So, yeah.
Well, I should say, all right, I'm gonna complain for a minute. One thing that drives me crazy is folks who are at nursing homes. They check especially levetiracetam levels on these patients. And it's like, oh, your level's too high. I'm like, well, they've been on the same dose for like 2 years. They drop the dose down. They have a breakthrough seizure. They wind up in the hospital. I'm like, why'd they change your meds? Oh, okay. So that's what I always tell all of my trainees. Like, don't check Keppra levels unless you're worried the patient isn't taking it or they're in renal failure. Otherwise, it's probably a waste of your time.
Yeah, that's a very good point, actually. Yeah, why would you check levels and monitor in any patient that has been taking it without any problems?
I think it's just a reflexive thing. You do see older physicians out there where you would check, like valproate or phenytoin levels, right? Like, that's appropriate, especially in someone who might be having altered metabolism as they age. But they start to cross-apply that to some of the more modern medications, which don't really have the same indications. But yes, that's my own particular soapbox that I have in my area. But I'm sure I'm not unique in that.
Let me, since I have you here, let me ask this question. If you have a patient, let's say on Keppra, he had a breakthrough seizure, you measured levels, they're therapeutic. Does it make sense to increase the dose to kind of boost the levels further up, or would you add another antiepileptic, depending based on you think the patient needs more coverage? There was no precipitating factor. It's probably just a matter of adding something.
Yeah. So typically, I would typically maximize monotherapy before adding in a second agent. Personally, assuming normal kidney function and they're tolerating it okay. And if they are on a middling dose, like 750 twice a day to 1,000 twice a day, you got a little bit of room to go up. I typically, if I'm up to 1,500 twice a day, some people will go to 2,000 twice daily. personally, I tend to find the side effect incidence goes up, and I don't really get that much benefit in most people. Now, if you're seeing like when you went from 1,000 to 1,500, you had a good reduction, maybe you can make an argument that they're a good responder and they just need a little bit more. But in my experience, I would say those people are the exception rather than the rule.
Yeah.
But a lot of times I'm a big fan of optimizing monotherapy just because of like med compliance. Obviously, when you get to, as you know, polypharmacy is a big independent risk factor for medication non-adherence, just due to the complexity of some of our regimens. So I tend to be a monotherapy advocate until you've kind of exhausted that line. And then I think it does become one of those questions. Did the Keppra, as you were titrating it up, did it make any difference in terms of frequency or severity of the episodes? If not, then I tend to be someone who would cross titrate to an entirely different agent as opposed to adding on a second agent on top of it. So it really does depend on the clinical response to the initial monotherapy, whether or not I would keep it on board as I kind of progress down that pathway.
Yeah. No, thank you. Thank you for that. It makes a lot of sense, actually. And it's a common scenario.
Right.
These patients, we see them quite often in the emergency department with breakthrough seizures. Yeah.
And that is right. That is the knee-jerk response, is just to, they're not maxed out, we'll just bump it up. But don't get me wrong, I do that very often myself. It's like, but as you also know, right, the main reason why people do have breakthrough seizures is, maybe they missed a couple doses, and we don't really need to do anything. In those patients, more often, I'll have the conversation about either changing it to an extended release form or to a medication that has a longer half-life. If compliance is a concern just because of missed doses on a repeated basis. So going to something long-acting like zonisamide, that would be an option, or eslicarbazepine, again, depending on interactions and all that jazz. But before we make this a seizure podcast episode, but
so easy to become.
For me it is, but as far as, so this is another situation kind of going into that that complex, right? Because like you said, it's rare that we get any one of these pathologies by themselves. When we have someone, we're thinking, they've got these microhemorrhages in the lobar areas, but we also see on the MRI, maybe they have had like a lacunar stroke, either acutely or in the past, and they've got some cardiovascular risk factors or cerebrovascular risk factors. What is the role of antithrombotic therapy, or, God forbid, anticoagulation in someone with atrial fibrillation? How do we navigate those waters?
Yeah. Those are difficult waters to navigate, but we have some answers. The way I think about CAA is that you can have symptomatic CAA defined by the syndromes, primarily the hemorrhagic, but also in the setting of a memory clinic. And you might have CAA as an incidental finding just because you got a brain MRI. And we know, again, from neuropathological studies, that CAA, again, depending on the age, is quite common. So having CAA incidentally in a patient who got a brain MRI because he had an ischemic stroke is a very common scenario. And the way you might identify incidental CAA is by seeing, as you said, a couple of lobar microbleeds. So before, partly because of the literature and the way the field in small vessel disease and microbleeds focus so much on bleeding, even the name microbleeds is a scary name. It involves bleeding in the brain. It's not a good thing. We now know that a lot of microbleeds, they're not even bleeding events in nature based on neuropathology. So it's a range. It's a range of underlying pathologies that cause what we see as microbleeds on brain MRI. So in those patients that have incidentally found microbleeds without any lobar hemorrhage, without siderosis, without clinical CA events, it's probably very safe to prescribe antithrombotics for secondary stroke prevention. And I'm saying this because we have good observational data from the CHROMI study, from the HERO study in Spain, and then from a large meta-analysis involving more than 13,000 people, who were all patients with ischemic stroke, with or without AFib, who had a brain MRI at baseline. They assessed microbleeds, and then they assessed for future events. And they found that even in patients who had more than 2 lobar microbleeds, a pattern suggestive of CAA, the risk of hemorrhage was always lower than the risk of ischemic stroke. So you need to look at the absolute number of events, not the relative numbers.
Okay.
So always in this particular scenario, the absolute number of events of ischemic stroke that are much higher than intracerebral hemorrhage. In other words, you get more benefit than harm by prescribing antithrombotics.
And
this is go ahead.
Oh, I was going to say, that's typically for monotherapy, I assume?
Yeah, based on the data, most of those patients, they were monotherapy, either Plavix or aspirin. Mm-hmm. There were some on dual antiplatelets, but very few. And really, the indications for dual antiplatelets, they're not huge. They're very specific scenario that the patient needs to be on DAPT and right. for specific time frame.
Yeah, I don't know why. In the last few months, I've seen a run of people who have been on dual antiplatelets for very long, like years, after a small stroke or something like that. I'm just like, yeah, you must have gotten lost to follow up at some point.
I think that there was one of the stroke fellows at Boston Medical Center who did a quality improvement study, because we started noticing the same, that patients after a minor stroke put on DAPT, they continue for months. And that was the reason, lost that follow-up or continued follow-up with another provider. And they just stayed on it.
And did you find, just my own curiosity, is it people who had kind of the lower NIH's minor strokes who tended to be more lost to follow-up?
Yeah.
That makes more sense. They're not as fixated on their post-stroke deficits, I imagine.
Yeah.
Very interesting.
Yeah, they were too good.
Right. That is what happens, right? No one wants to go to the doctor.
Yeah.
Any final thoughts? I feel like I've learned a lot today, and I very much appreciate it. Anything else that you think the medical community at large should be cognizant of as they're out there treating patients with neurologic disorders, transiently cognitive decline, etc., that you think would kind of improve the care in their community?
Yeah. So I think if we are to close with like a couple of take-home message, is that to make a diagnosis of CA, when you have a relevant scenario, you need blood-sensitive sequences. Otherwise, we're just talking theoretically and potentially harming the patient. And now we have very good blood-sensitive sequences, especially the SWI, susceptibility-weighted imaging. It's much better than the T2 star GRE in visualizing siderosis, microbleeds. So these are better sequences to make a CA diagnosis. So you need that. If you assess a TI patient and you get a brain MRI without blood-sensitive sequences, then you're missing the opportunity to make an alternative diagnosis.
So for those of us who only have GRE at our institution, how many do you think we're missing? A lot of patients. Let me put it that way.
I'm not sure how many are missed. I would assume there are not many. It's just with SWI versus GRE, you can see more.
Yeah, that's true.
Now, if at your institution you have an 1.5 Tesla GRE, then if you compare it with a 3 Tesla SWI, maybe you're missing. I'm not sure. I'm not sure. Maybe 10, 15%. Yeah. I'm not sure. Okay. We don't have the data.
I gotcha. Yeah, no one's running that study, I'm sure.
We have the data from patients who were already diagnosed with CA or they had microbleeds on GRE. When you look at the SWIs, you just see those same microbleeds better and you see more.
Yeah, makes sense.
And in a few patients, you see microbleeds or siderosis that you didn't see in your GRE. Or if you go back to the GRE, an area that looked a bit blurry was actually siderosis or a microbleed. So yeah, I think SWI should be the standard of care going forth. And the second take-home message is that we shouldn't be so afraid of microbleeds, in the sense that not all microbleeds are due to CAA, not all microbleeds are microhemorrhages, and outside the clinical syndromes of CAA, microbleeds should not hold off from prescribing antithrombotics in a patient with a real indication, especially when it comes to secondary stroke prevention or prevention of MIs. Because I think the tendency is to be over-conservative and not prescribing these medications just because there were a bunch of microbleeds incidentally on a brain MRI.
That makes sense. And obviously that the emphasis being on the micro part of the microbleeds, right?
Yeah. Yeah. Just to clarify, the microbleeds, they're not small version of lobar hemorrhages.
Right.
It's an imaging construct in a way. Mm-hmm. And they appear black and scary on SWI and T2 star sequences. Their real size is likely 10 to 30 times smaller in the brain than what they appear to be on the MRI. There is a susceptibility artifact, as it's called. So the distortion of the magnetic field is much higher than the actual size of the lesion. Just to give you like a concrete example, you might have a microbleed, and when you look at the pathology, there are 3 macrophages with hemosiderin. That's it.
Oh, wow. That does put it in context.
Yeah.
Well, Andreas, thank you so much. If people want to find you online, where should they track you down?
So I'm pretty active on Twitter at Charidimou, my surname, so they can find me. And they can also email me. I can share my email if you like.
Sure, go for it.
My email is Andreas with a D .Charidimou, my surname, .09 at ucl.ac.uk. Or, you can send me a message on Twitter. It's easier.
Sure. I'll include a link to your Twitter bio on the show notes today as well.
Yeah.
And thank you again. I think this was very educational, a lot of good information. I very much appreciate you taking the time to talk with me, talk with our listeners. And thank you. Really appreciate it.
The pleasure was all mine. It was very nice to get to spend some time with you after all this time that we have been interacting. And I definitely learned a lot from your questions, and I learned a bit on epilepsy as well. So bonus.
You're too kind. Too kind.
Thank you.
Thank you again for listening. This episode was edited and produced by Rita Farhan. If you enjoyed this podcast, please leave a 5-star review for us on Apple or Spotify or wherever else you might get your podcasts. This really helps with getting the show noticed and spreading the word. You can find me on X, formerly Twitter, at Dr. Kentris, DrKentris, and you can find the official Neurotransmitters feed at neuro_podcast. Lastly, you can find a lot of our content online and keep in touch with us through our website at theneurotransmitters.com. Thank you again for listening, and we'll see you next time.